speak to us. Yeah, welcome. Good to see you back again.
Thank you. Thank you very much. So thank you and welcome to everyone. I'm going to talk briefly about UHC NHI background, and then we'll talk about contracting in primary care. Some global experience will be covered in the background. And then we talk specifically about models of possible approaches in South Africa and what may emerge. So I think it's important to understand that, as far back as Alma Ata 1978, I think we talked about the need for covering populations and developing a primary healthcare approach. I think the primary healthcare document in the World Health Report 2008, which was a 30-year celebration of Alma Ata, brought up four ideas, which were very important. One is that PHC will never improve without universal coverage, which talks about how do you build a way in which everyone gets access. How do you get that happening? Included in those ideas was that there needed to be service delivery reforms. And a lot of it was about how do you focus people around people instead of just lines and queues. And I think that's the public health system to some extent that is challenged. And I think it's also true for the fee-for-service private service as well, that sometimes it isn't it may be person-centered, but it's not people-centered. And I think leadership reforms is about trying to get the public service, in fact, to realize that it is not just responsible for public provision, it is responsible for the overall health sector, including the private sector. And I think that it needs to both regulate it and recognize it as an important part of an overall government's plan. And the public health reforms is just the whole idea of health in all policies, and that it is, the primary health care is not about the health system only. It goes beyond. So I think these were key efforts in terms of defining, this is globally, and the Astana Declaration 10 years later did much of the same, perhaps putting in some more detail in some of the things. And I think if you look at that PHC levers, both strategic and operational levers, you'll see right at the top models of care, the workforce, and a bundle of other issues as being really important to the development of appropriate primary health care going forward. Knowing that the world and World Health Organization cannot define things very well, but I think this is a really important idea that we need to think carefully about how we implement primary health care, especially with different models of care. If you're looking at a PHC performance initiative, which in fact has been now incorporated into a WHO document recently, to capture much the same in terms of looking at monitoring and evaluation of primary health care effectiveness, it is really this black box that many a times is not accounted for well enough in the building blocks that often people use for public health. And I think it is the kinds of things that happen where clinicians are aware that, the availability of effective PHC services depends on providers, both their availability, competence, and their motivation, and the safety and trust, and that high quality is developed through not only first contact accessibility, but continuity, comprehensive coordination of person-centered care. And that this is, has supported by the sort of access issues that are defined globally, and the fact that we have a population management approach, which is moving towards empanelment, which is a very important principle, that you're not just managing patients, you must manage populations. And so the team or the facility needs to respond accordingly with the kind of thing that needs a panel to be managed by a team, and then, of course, a lot of other things that go with it to strengthen our management. This is a global perspective. In Africa, the conversation's actually been quite slow, but it has grown in the last 5 to 8 years. And I think these few documents in the WHO space in Africa have actually been very definitively moving away from the verticalized programmatic approach of selective primary health care to saying we need a very comprehensive, person-centered, people-centered primary health care. And if you read these documents, be very, delighted to see that kind of approach emerging in Africa. So what is universal coverage? I think it is simply trying to get as much of the population covered by as much service as possible, with as little cost to the individual as possible. There's no such thing as zero coverage. There's always something somewhere, even if people pay out of pocket. So the idea is that this is a journey, and there's no place in the world where there's 100% of any of these, because there's always some gaps that are a problem, and it's usually a societal prerogative to sort of edge better and better towards a universality. And I think that's the journey we are going through in South Africa, and we need to see that as a journey and not a destination. That somehow NHI Act is in place, and suddenly, voila, everything is in place. It's just small steps on this journey. Well, the Lancet Global Health Commission on Financing Primary Health Care brought up some important principles, specifically looking at the financing element, which we'll see in the NHI, is that one is the pooling of funds. And many a time, I think the conversation has been mostly about the pooling, including public service. And I think that's somehow unfortunate in terms of the conversation. Strategic purchasing is really very important. And this is something, that any government now has to think carefully about. And that's why they are basically building up these funds outside of government, or a little bit collateral to government, to allow the strategic purchasing, because this is not easy within the current government systems. And then, of course, how you in primary care pay, they suggest the very blended capitation approaches. So I think UHC in South Africa, the question is, well, it is an important commitment to it. I think that started with our democracy in 1994. And I think we were very fortunate in moving from very, very poor universal coverage prior to 1994 to, in fact, a fair coverage with President Mandela by 1996, creating a system in local government clinics, adding primary health care nurses to them, and allowing a certain package of service to be delivered quite widely across the country. And that, over the 10 years plus and still ongoing, has been sort of to try and spread that and ensure everyone is within 5 kilometers of at least that package of services. I think we must also recognize that with the apartheid demise, private deregulation was a key part of that demise. Most of the deregulation in the private sector occurred in the 80s with the sort of machinations of the apartheid government to try and retain privilege. And I think that sometimes people don't recognize that as a reality that we're sitting with. I think our constitution is established in 1997, local government later. It was only 10 years later that the district health services were established. And I think they're still, I think this problem of the public-private divide has become more and more acute. And I think patients are themselves pushing for the fact that where is I can get a private GP, why can't I get that in government? And I think that is the disturbance that we see in South Africa, that this is a major contention in the population. And I think it's something that the government recognized with the NHI Green Paper. And I think it's been waylaid by capacity and state capture and the COVID-19. But I think that is really the journey that we are on. I think the other thing that we need to recognize is that in South Africa, our government has literally achieved the Abuja Declaration of 15% of its public health spending, total government expenditure, to actually commit to health. And that's not an easy thing. If you look around in Africa or many other parts of the world, not an easy thing to achieve. Our government's done that. But I think that whilst it's done that, this has not, this is for a population totally, and you can see there's a slow growth in the cost or the public spend per capita. And if you compare that to the private, is clearly with the deregulation, cost escalation that has skyrocketed. And this is really the divide that I think is becoming a bigger and bigger problem in our country. Of course, for those who have, it's great, but the problem is that those who don't are not sitting far beside it. And I think that can only make for a very unstable society. And I think those who see their privileges need to just look at the bigger picture and realize that there is need for a much more sustainable approach going forward. And I think that, yes, this is a slide that Dr. Crisp, Professor Crisp, shares, and I think it does speak of the very big difference between costs between the public and the private spend. If you're looking at the, from 5,000 to 25,500, you might have that collective spend at around 10,000. But yes, there may be improvement with the, with the people who are not in the private sector, but there's definitely going to be a drop in the quality of care for those who are in the private sector. But I think that is also a very false narrative. I think there's a whole lot of processes in that we've got to understand. And I think a lot of it's about, are we wasting things even with the 5,000? That do we need double to achieve? And I think you'll see in the presentation that it may not be. And is there in fact good quality emerging from 25,500? And I think there's lots of questions about that. When you look at some of the things that are prevalent in the private sector, like 15% or double the amount spent on GPs going to administrators. Those are the kinds of difficulties that we face. So yes, we've, in all the work that I've done, we stress the fact that primary health care is a very important begin point. I think government recognizes that. And just looking at this little depiction here in the private sector, and this is key care as an example, with 2,000 at its cost, 7,000 is the cost of hospital care and per capita. And if you're looking at the public service, it's 1,000 rand at that. This is dated. It's about 45 years old. But at 1,800 rand, you can see that with the hospital sector, there's probably a huge divide to the lowest sort of amount for hospital expenditure compared to the public service. The gap is big, but the gap between primary health care in public service and primary health care in the private sector is not a very big gap, at least in real terms. And I think that too, there's, I think, a very sweet spot we have where over time we may be able to bring through very good engagement at a relatively easily achieved price point in primary care, that we could in fact drive the costs of general hospital care and all other costs within the health system that we may achieve an NHI that's very affordable. Of course, we'll have to be quite innovative, and I think if we all put our heads together, there might be some really great solutions. And I think that's really the opportunity to see is that what we are looking at is not, the private sector collapsing to the public or the public becoming somehow private. I think there's something in between that we need to see carve out and build slowly that provides value for money. And I think that's really the conversation we need to have, and not these apocalyptic type discussions. So it's important to understand what is the NHI all about. And I think that what is going to change. And we had to go through a lot of education in the district and the Department of Health to make people understand that really it's not doing away with the whole district health service as it functions now. All it's doing largely is changing the way in which funds flow. And these funds at the moment flow basically from population to the National Health Treasury and then down to provinces, districts, and it kind of trickles down. You can have a situation where a community health center, which has a budget of 100 million, and you ask the manager, how much do you actually control? And she'll tell you, the petty cash, 5,000 a month. That's all I can really influence. Everything else goes up higher. And this is where a lot of the hidden corruption that's in these provinces and districts that, is very difficult to unravel. And that, I think, is largely the problem. Line item budgets are also a very difficult system because of the rigidities of government, but also because of the fact that the more you spend, and if you overspend, they literally reward you by giving you more money. And that isn't needs-based. It's basically demand-based. And that's not a very good way. Those managers in poor areas don't know how to manage will actually not give more to the population that really needs it. So that's the one challenge. And then, of course, the other side is a payment system that out of pocket or medical aid goes to various providers, and it's usually on a fee-for-service basis. So these are the two sort of diametrically or opposite ends of the payment system, which drive different behaviors. And we think we all know that there is a tendency to over-service with a fee-for-service environment. So it's illness-focused, not health-focused. Now, the fragmentation of funds and I'll come back to that slide to show you the change in the way in which payments happen. But I think the fragmentation of funds, people don't realize that, in fact, in the public service, there's a huge amount of fragmentation with funds in different places, even in provinces, that create this kind of inequity within the country. And just looking at the spend in primary health care, you'll see that there are some places that are in parts of the provinces, like in Sedibeng, let's say Gauteng. In Sedibeng, it's literally 1611 as an amount spent. Yet in Johannesburg, it's 600 rand less at about 1,000 rand. And that's inequitable, and it isn't easily explained. You look at Ekurhuleni versus Joburg, again, why the difference? And it isn't necessarily adjusted for the individual who is needing the healthcare. And I think we'll come to the question of adjustments. But this is a question. Even Namakwa, Qarib, Central Karoo have big distances, but does that justify entirely being double the amount spent in Alfred and Zo, which also struggles with very difficult terrains? And so there's a big problem, and it usually is that the provinces themselves make arbitrary and uninformed decisions that are a problem. So I think that, for starters, it is about bringing the public fold into the fund and finding ways to better inform that, and slowly to be able to bring funds into the system over time. And it cannot simply collapse the funds held by medical aids into an NHI funds. These belong to the trustees, and so it's protected in government. But I think what's important is that there is an opportunity for strategic purchasing, and that's really where we need to look at what is it that's going to happen. So the NHI fund effectively is allowing it to send funds not via the circuitous bureaucracy, but directly from the fund to these different entities. Now, of course, in the district, in the public health service, they'll have to figure out exactly where and how they're going to contract with the NHI, and it'll depend on how the NHI decides itself how it wants to, at what level it wants to see the contracting happening. And I think there's a strong push to find it at a much more decentralized level than a district. They literally wanted a sub-district, and in some instances a sub-district, to reach these providers right on the ground. On the other hand, it's really that this is strategic purchasing, which means that it's not the usual budget of fee-for-service. It's a mix, which is predominantly capitation, some performance payment, some fee-for-service, and some item budgets, some line budgets that may come through that will be part of the mix. And this flexibility can only happen in an organization that's not formally part of government as it is, because of regulations, and allows the NHI to then do this in terms of payment and create an environment, and importantly, engage with the private sector. So many people, sort of talk about the nationalization of the private sector. I think it's a lot more about privatization of the public service by bringing the private sector provider into a publicly mandated system. So I think if you're sort of looking at that mix, I would tend to look at it opposite to most people. So what is likely to happen in the PHC sort of area? Well, people need to understand line item budget is usually per facility. It's very demand driven. It's paid in advance. It's kind of simple, but there's certain risks to it, that it creates non-responsiveness. You get the money, it's spent, and it tends to risk the providers very little, and they just simply spend without thought about what's really happening. On the other side, or the middle of it, is basically a fee-for-service environment, which is in the private sector, South Africa, in the USA, and it's a per visit. It's again very demand-driven. Paid shortly after, it's very admin-intensive, and it tends to be responsive, but the risk is over-servicing. And again, there the risk is high. is low for the provider. Capitation, on the other hand, you've got places, I mean, the UK, New Zealand, growing in Canada, I think growing across the world. But it's a per person per year. It's usually not paid per year. It's paid in advance, usually monthly, but the amount is negotiated as a per capita amount. It tends to be very need driven, and that's really very important in the way risk adjustments happen. As I said, paid in advance. The benefits is that it's a very simple administration. And it can be fairly responsive to the needs of patients. But the risk is, again, that it creates this moral hazard of underservicing as well as over-referral, because obviously the provider has more risk in terms of managing this process. It's not necessarily high. There tends to be, and I think this is part of the whole negotiating of how do you actually manage risk in this environment and not overload risk. Usually the sort of capitation gets a bad rep in the US, largely because they have taken capitation very widely rather than for a narrow set of primary care services, and often involve hospitals as well. And that is very, very high risk. And that's not the way in which the plan is to go. I think performance payment has grown in the UK, with the QOF in the last 30, 40 years now, and increasingly in Africa. But again, it's based on performance. It has its challenges. I think it needs to be data intensive, and it usually comes along as sophistication grows. In most places, this is the kind of basic mix, and it's usually a sort of predominantly capitation and then bits and pieces. In some places like Croatia, you can have about up to 15 little elements that can be part of these negotiations. But the idea is to start simple. And this is the advice by the Lancet Global Health Commission on this. Say, start simple, you may adjust. The adjustment, and it usually is based on data, and it could be achievable in South Africa by looking at current schemes that work on a capitation. There was KeyCare, and now there's GEMS. And they can develop this adjustment based on their data that they usually adjust on an annual basis to say, listen, age is a big consideration to the cost spend. And they build up factors that allow one to adjust for age, adjust for gender, adjust for socioeconomic status, where rurality can be built into it. There are factors and denominators in the country that can, or numerators in the country that can look at the denominator across the country and adjust for such conditions. Even townships, morbidity, HIV/AIDS, diabetes, etc. These can also be available. And of course, it all depends on the data. And if it's not there, it gets built up over time to become adjusted. Blended means that it adds fee for service into the mix, and there's different rationales when they might come in, some fixed payments, some performance payment. And that's the kind of subject of negotiations at a national level. Usually across in these settings, these tend to be national contracts, and they can be managed quite simply. In the UK, as an example, they have they only have one contract essentially signed, which is when people enter practice, they'll sign the initial contract. After that, they don't even sign another contract. What happens is the contract itself speaks to the fact that there is a committee of Parliament that meets with providers, negotiates the rates of various elements of it, and then the government, once agreed, gazettes this, and that has legal basis for the functioning of the system. And so there's no need to sign contracts annually. And so it's very low admin, and I think that would be the preferred way to go. I think that the idea of capitation as a payment is scary. So I did a study in 2011 with GPs in South Africa, 900 out of the 9,000 at the time, and essentially put to them a scenario of 10,000 visits per person, 10,000 people that are on a panel, which is an unusually large panel. But given the fact that 6,000 people could cover 60 million, that was just saying, listen, a practical mix would be this amount. So essentially, they came back saying at 3 visits per person per year, and we said that's 120 people. We found that they had a very strong team-based approach where they grew their practice numbers. They said they would add on staff, mostly nurses. Their pricing point turned out to be just literally R1 more per month than the whole Johannesburg Health District was costing the public service in 2011. And yet, when we looked at their own charges and adjusted for some of their elements, they literally earn much more with the capitation than their current fee for service based on that low charge. They came up with risks, and we asked them what risks and what mitigation. The first risk they brought up, or one of 3 risks they brought up, was don't trust government. And what they mitigated was we need a very strong contract, and I think that's a given and needs to be understood. And these are the elements that people need to think about. The second one is they thought that the visit rate, which I proposed, was low. And of course, there's debates about how you manage that because it's the biggest cost driver. And of course, their mitigation was a very promising one. Most of them said we do out promotion to keep people happy and away from the practice or wasting resources in the practice. But I think a few of people said they would limit access, and that's not going to be okay. The third thing they brought up was a paradigm shift. That they are currently small, and suddenly we are talking about this big practice with big teams. And they said to manage that risk, they would have to be very skilled in management. And of course, that's a key question. So in the work that has been done, I'm a project manager for the Joburg proof of concept of the CUP. And it's Gauteng's project. And essentially, we said, let's look at the current provider contracting. And at the end of it all, it is all very inefficient. Perhaps the one that's still happening, which is really a fee for service, is the mother and child, which is expanded to include other elements, which is a fee for service where people are given a free consumable and then allowed to charge for the service around it with a sort of stipulated maximum charge. But that's patients paying. So I think we have also been battling to try and understand who are the providers out there. And I think that's really an important thing that we're busy with now that the Act is in place, is to try and reach out to it. I think the possibilities have been discussed at various forums, and I think this is still going to be a discussion point. So I'm just going to say right here now, these are just ideas. I think that there are some places in the country where people are saying, let's only treat conditions. And unfortunately, there's no way you can pay for that except in a fee-for-service environment and not capitation. And there's some people that sort of are debating that. We've said in Gauteng that really there is no way you can pay per capita without a decent package or package, but related to a person, because a per capita is a per person payment, and you have to understand that risk. And we've said that the only possibility less than what we're proposing will be to take under 6s, over 65s, or pregnant women as a group, as the belly button, so to say, and that you can narrow that range of services. But I think that given what we've had experience with in the 1990s, people are not going to be happy with that. And so we've proposed, listen, let's focus on a current clinic, which is quite pervasive and universal, and find ways in which we can ensure that there is a doctor attached to it. And at the same token, this model of a doctor with a clinic can work both with GPs, then building up a team, as well as with having, the Dis-Chems or the Unjanis all working in this configuration where they already have got engaged in models of this sort. I think that we've said the whole idea of a multidisciplinary team is asking a lot to understand right now, especially price points. Mixing that all up will be very complicated, but I think there's still sort of discussions that need to be held at a high level for that to be worked out. But we think that really there needs to be a lot of work done because the price points between public and private are really hugely apart, whereas this particular service package is much more achievable. Like I say, there are all sorts, and I think the HPSA has come to the party by amending ethical rules and allowing a lot more of flexibility in terms of employment and team-based approaches. And I think that's something that's welcome for everyone in the field. I think it just allows a lot more flexibility. The OHSC also has developed a GP inspection tool. Hopefully people have been part of that engagement in the attached, in the presentation. I'm not going to share it, but we've actually put some more details to these domains of user rights right down to facilities and infrastructure. It's a long document, it's easily available. If you go to my website, profmoosa.com, you'll find the thing if you just look for the OHSC. But this is something that is worth looking at, and it's a very empowering document. They not only say this is what we want and need to see, but they in fact said how they think it should be done and provide very sort of hands-on advice. So how could this work? I think the current idea is that there is a health patient registry system that is being developed by a body, I'm just trying to figure out which body it is, but CSIR, which has basically housed for the Department of Health a way in which all their data that they've been collecting at various health services across the country have been registered, but it's not really that critical. What's happening now is these patients are being linked into the Department of Home Affairs and validated with fingerprints. So essentially a GP or any provider would be, once contracted past, with the OHSC, is accredited for any other requirements, then basically will need to have an HPRS connection, will be given that, and essentially there'll be a module that allows the provider to enroll patients into it based on a valid fingerprint. Of course, we've suggested panels start from 2,000, 2,500, up to 10,000 to allow people to grow into this process. With 2,500, they'd be seeing about 40 patients a day, and it's not impossible for them to get into this. And it may, in fact, be quite lucrative, especially in low-income areas. And I think that people can then be pushed towards team-based care to ensure the redistribution of doctors and make sure that team-based approaches are much more common than we have it right now. So this is a way in which that can happen. In the public service, that's also a consideration. How do they make sure everything is connected to the internet and HPRS is functioning? A provider, like I said, the service package could be unlimited free consultation. It's a principle. PHC guidelines being there and guided in some ways by the current EDL and standard treatment guidelines, but allowing for South African guidelines to be broadly in place. I think one of the key things people need to realize about a service package, it's not necessarily the service package that is a strong limitation to care. In fact, I've argued that too much detail actually limits care. What the best way to manage services, is to in fact look at the medicines and investigations. And I think that's going to be a considerable amount of the discussion, is not just the service provision or the service package, but in fact some of these hours, services that are expected, and medicines and investigations. Maybe some of the procedures, what's expected within it, what's going to be paid for in addition. And then I think preventive services, how might that be managed? But all of these have been discussed and are fairly happenable in the context of a small project. And we've said, listen, this is a way in which we can set it up. We've also said that there need to be some important principles without which there will not be the right kind of embrace. If people just say, well, I'm signing up for 2,000 and carry on as they are as a GP or any of the providers, they in a very biomedical base approach, it's not going to be very helpful. So we've strongly advocated for teamwork, and that is including nurses, including clinical associate pharmacists and CHWs. Some of this, of course, is going to be questions that you'd have to ask, is that covered or not? What is covered? And I think that's part of the negotiating. But I think that there's going to be an expectation of some quality in terms of some of that. So lots of work to be done around, what kind of positions do people want to take. But community orientation is really very, very valuable. And we've stressed that there must be a way in which this can be there, not just because it seems like a nice to have, but we found, and I'll share a little later, it's been absolutely essential to drive the utilization down while increasing the quality of care. And we've said that it needs to be with strong record keeping, where you have community health workers linked strongly to the population, and there's engagement with the PHC leaders or leaders of the community, and then using all that information from those 3 quarters for targeted health promotion. And of course, one has to guard for this sort of discrimination that might occur going back in history. I think the third one is that these referrals are a very, very strong element of you might say managing the process, but enhancing the process so that patients get appropriately referred and seen quickly, but the inappropriate referrals are managed appropriately as well. So I think the idea is to set up a referral network. We're busy, and I'll share a bit in Joburg, and looking at setting up peer review systems, as well as trying to support people with training, but also to progressively include other contracted providers at a higher level into the system, where the current referrals might be to the public service, but then it will progressively increase. And I think this is the opportunity for a marked change in costs. Data collection will be absolutely important. We've said if you don't get that going right at the get-go, a big problem. It doesn't need fancy electronic health records to start. Even the current payment management systems with EDI and ways in which you can actually get certain information through that would be able to get you good value and good outcomes quite quickly. In referrals, we've talked about it needs to be very clear for any GP, any clinic, anywhere in the country to know exactly what they refer for, to whom, and where might they jump that queue. And that needs to be very clearly set out. And we've also been strongly advocating not only for a written list to be shared, but for the Vula app, which is free to be used in a way that's easy and prevents you to just send people up and down, but in fact to communicate with higher levels with that. I'm going to share this briefly, but it really is all over the show. It's public information. If you're looking at it, on the right-hand side, key care basically cost in 2018, 1,220 Rand for 4 visits per person per year. And if you look at it, the public service in 2019, 2020 cost almost the same amount for 2 visits per person per year. And that shows the degree of waste in the public service and the opportunity that exists for better pricing and better availability. Of course, that's part of the negotiating. We've looked at trying to unpack the current public health spend in the Joburg district and come up with some low amounts. But it also speaks to the fact that there's a lot of waste somewhere in the system that creates this kind of disparity between the per capita spend and what is happening in Joburg. Joburg's about 1,000 Rand at that same time, but you can see there's some challenge in terms of the costing or the way in which money is spent in this district. And I think there was even some work done with the providers in Soweto, clinic managers, and we asked them how would you, in your ideal world, with 2 visits per person per year, they came up with 2,000 Rand, which was just way out when you look at the costing. And I think it's very important to understand the COPC rationale, that even if you are dealing with 10,000 people, at 1 visit per year, you'd be seeing 40 people. And whereas if you don't manage it well and you're not using these principles, you could land up with 240 patients. But the premise of the pricing, I think, will be linked to some understanding of utilization, but something that would be reviewed. And I think the key question is how do we navigate that terrain? As I mentioned before, the COPC approach, population management, reorienting the way in which you function to link yourself strongly to community health workers and your full population, not just the patients who walk through the door, finding ways to engage with key stakeholders and using that insight to do targeted health promotion. We found in Shiawelo, where I practice, clinically, we found that we got a utilization rate of less than 1. So that's incredible achievements by using simple approaches. We've in fact put on the cards, which is near the Shiawelo CHC, where CCP or Shiawelo Combi practice functions. We suggested 2 clinics and the communities in Ward 15, 16 that are being supported by those to sort of look at contracting providers in that space and finding ways in which we can see by halving the population and contracting half of it out, you're doubling the budget of that facility, as well as giving opportunity for new providers to come in. So just in closing, I'm just going to say there's a lot of talk about the cups. And I think that's been somehow adjusted in the Act, being reduced a lot more. And essentially, we've said that really the key question in the contracting is about the coordinating mechanism. And there is the whole idea that the NHI will have some coordination, but the district or the district health management office, which is still the same district, but is going to have to find a way to not only devolve the sort of delegations to providers at different levels, their current public providers, but they're going to have to take on a much stronger role of, at a sub-district level, of trying to support policies and programs with all providers and ensuring they're all achieving the outcomes that are necessary. So I think that we're finding is really a very key thing. And in Johannesburg, we are basically working on that kind of engagement with people who are already contracted to provide mother and child stuff. In the district itself, we said profiling, we're struggling with that information. It'll probably come with time. We've stressed the HPRS as an IT as being very, very important. We've said we need to define this package and test the model. We've done that. We are looking at this clinical governance, but a lot of it about functional referrals. In that respect, also strengthening the sub-district managers and developing the shadow budgets and functional business units and cost centers, and then exploring how the private sector might be engaged as we're going forward. So at the moment, this is Johannesburg as an example. We have A to G regions, and we've got 6 forums that are going to become quite a principal space for providers to be engaged, both at a district level and at a sub-district level. So I hope that gives you a feel for what might come as we go forward. But I think that I'm not sure that there's enough time. I hope there is, but questions would be really useful if people feel their questions haven't been answered.
Thank you very much, Prof. Moosa. No, there's sufficient time and you've given us quite a extensive overview of what you've been able to do in that pilot in Soweto. And there are quite a number of questions already that we need to deal with. But I think the approach for this webinar was that we're moving from the premise that NHI is a reality and say, what is it that we can do to work within the framework of what the Act has been promulgated to achieve. So I think there's a question here, will private nurse practitioners be considered for being contracted in the implementation of the NHI?
I think that please be careful. I am not speaking on behalf of the government. I'm not on my cap. I've been very clear. So I'm speaking as a WITS academic. I can only speak to the information I have, which is very limited in terms of what is exactly going to happen. But what we've proposed and what has been discussed, and this is work done in the academic space and in the sort of practical development place where we are, we've said, listen, it should apply to any of the different configurations. So Unjani, as an example, could easily configure it. One of the key challenges, and this is part of the whole management of capitation, is that if you do not manage well referrals, you will find that costs to be driven up and uncontrolled. It's one of those moral hazards. One is denying patient care, and the other is over-referring without scrutiny. So there has to be an accountable doctor. It's the nature of the beast in the United Kingdom. And I think that we need to embrace that idea and make sure that before anyone is referred to a hospital, they go through a doctor. Now, that in an example like Dis-Chem could be the online doctor that is there and ensures that a letter is sent appropriately. He's also got to be part of peer review processes, because when there is a discussion, and this is some of the things that we are going to punt, say, without that, you're going to find that this doctor doesn't understand issues, we can't engage with him. So there's gonna have to be a lot of thinking about peer review processes at a very local level in a sub-district. So it can be online, but I think the configuration is very important.
Okay.
So yes, to your question, I don't see why not.
Okay. I thought you're not going to answer it. Thank you very much. Yeah, so the answer is yes, they'll be part of it. Yeah. And you mentioned Unjani Clinic because this you worked with them also.
Yes, it's Unjani, Alma. There's a couple of them already. There's a lot of creativity coming forward, which is really good.
Yeah. And the GPs also, I mean, in that area, it's now one area where the GPs in private practice involved.
Yes, I mean, we invited quite a few people to come to the Shawelo, especially at the CUP discussion level. There were a few people from the local area in Soweto that came more regularly. A lot of people came in and out, and I think the providers are various. And in fact, that's one of the difficulties is, a lot of people are interested. I'm sure the audience here is huge and very varied, but we were trying to focus on primary health care, and we've got GPs, they're partnerships, they're sometimes groups. There were nurse groups, Unjani, Alma, etc., and we realized there are quite a few of them. There's also the pharmacy groups, which are now having their clinics and linked up to doctors, so they could easily also become part of this configuration. You've got I think those are the current set that we saw as coming forward. We are planning in Joburg to have a convening of a meeting to try and build up trust and engage quarterly at a district level, and then to pan that out at a sub-district level, at least quarterly, so that we can get people engaged better, and then slowly draw them into these processes which they are going to be at some point needing to be part of. But I think it'll take a bit of education and understanding on both sides to go that path.
Now, concentrating on the CUPs, what would the different considerations be for implementation of the CUPs in different settings, e.g., urban versus rural areas, considering the limited access to health services in the deep rural areas?
I think the key problem, like I mentioned now, is the question of the CUP role overlapping with the district health management office role. And I think that still has to be worked out. And at the moment, the CUP and the Act actually tasks the DHMO to, in fact, set up the structure. And remembering that, and then this is what we've looked at, saying, if you're looking at the NHI, yes, there's certain elements that they're going to want to come in and do. Like, for example, listen, we are here about the contracting and engage with the process, with the monitoring of some of the elements of it. But I think it's going to get team. So whether the CUP is a formal CUP that is convened of certain people, that includes managers and does some of these particular things, and there could be several forums, but the district also needs to have at a sub-district level a coordination process that will unpack, for example, what people know about policy and program, and ensuring that people are addressing programmatic outcomes in their practices. And then the second thing is particularly in terms of dealing with the referrals, whether that's a separate forum, but I think it falls within the Department of Health. And then complaints are between them. So that covers the kinds of issues. And of course, in that space is about making sure, identifying and engaging private providers. But that, is the sort of initial process. Once it's kind of relatively settled, it's about dealing with these issues, which I think anybody in the private sector now would say, that's a real pain point. We would like to deal with patients more comprehensively, making sure that whatever services, they need, they get everything by us, and make it easy for us to refer. Of course, the question of drugs and medicines are going to be something of the issue. How that pans out exactly, we've catered to the fact that would be delivered to doctors or any provider locally and for the beginning project. But of course, scaling up would be another story.
Yeah. The other question, which is not necessarily part of this presentation, but it's been topical, the future role of the district versus the provinces and the national? What would
remember that in the Act, it actually says that the DHMO is going to now be directly accountable or an appendage of National Department of Health, which means that anybody employed, I suspect they're going to take all of those people. So everywhere, anywhere in the country, everybody will be part of the National Department of Health, no longer a provincial department. So, but the Act allows the president, the Minister of Health, to pass the control back to the province as an agent. So, in other words, the provinces will very likely get back what they're doing. They will do what they do now, except that in time, money won't be flowing through them to the district. It will flow from the NHI fund to the provider at a level. Maybe whether it's the district, sub-district, or lower, big question, but the funds will flow directly. So my salary will be something that will be dealt with at a district or sub-district or a facility level. I mean, not a facility, a sub-district level. So it could be a CHC as an example. So I think that is the real difference. And so the province will do what it's doing, except, all the dribble through will be removed. And the sort of corruption possibilities, in my view, would be a lot less, because I can tell you that manager at a sub-district level, she can't be corrupt very easily. Everybody's going to notice her new Mercedes-Benz and fancy house because they all live in the same community. So it's much harder to hide corruption.
Yeah. The question that you've explained the numbers, does this mean that the practice with its team we'll see about 40 patients per day? What about the quality of care? Would that be compromised, and issues about complaints, as we've seen in the UK, limited to see a certain number of patients, and that leads to a long waiting list?
Yeah. I think that if you are familiar at all with the UK, there is a big push towards team-based care. Of course, patients in that space are very used to their GPs, so they're much more reluctant, and I think that wouldn't be different with our patients in South Africa. But there's no doubt that there has to be team-based care. So to assume that you as a GP have to see 40 patients a day, I didn't say that you're going to see 40 patients a day. I was painting scenarios. And how much of patients you see a day is going to be a function of a lot of this discussion. But you need to think differently than just thinking 40 patients a day. You got to think that that is a number that you can manage as a provider. You need to sit and say, how much do I contract for? Maybe I test and see for 2,000 people as an example. I see what happens. And yes, if I can embrace good practice, team-based care, I'm not somewhere else and letting a nurse see these patients, because they're going to pick that up and they're going to walk, and they can walk with their money. You may not succeed very well because others are going to have a much better system than you. And that is a team-based approach where the patient feels happy. Nurse is seeing me, but doctor's always there. And in fact, I get to see him and I can see his presence in that facility. You then have to sit and figure that out. And you say, hey, hang on, I've employed all the good practice that Prof talked about, and I'm seeing 10 patients a day. I mean, I don't even need a nurse. I'm doing all this stuff myself. But you'd be silly to say, oh, I'm happy, with seeing these few patients. You'd say, hang on, if I can do that, I might as well, instead of seeing 10 patients, I might as well start growing this and taking on more people, and in fact, getting more nurses and being more creative. And the ideas we talked about, building this team-based approach, not just for clinical care, but for population care, is the big paradigm shift. And there are ways in which we can do this. We've done that effectively in Shawelo, and the government is moving in that direction, except that the community health worker program is not functioning in the way I think optimally. And I think that is a sad loss. But again, I think that any private providers, they get their heads screwed on right, they can do this very well.
Yeah. You said there's limited chances of officials being corrupt at the district level. Now that all the funds are being managed national, what about national treasury? Are there no chances that they can also be corrupt?
I think, that question is something that I find quite strange. I mean, GEMS is the almost as large a discovery. And nobody's actually turned around and said, hang on, GEMS may be corrupt. Has anyone asked that question? Because that's government. I think that we need to just be a little bit level-headed in the way we talk about it. But I think just in a practical way, the idea that somehow this will be sloshing funds, it's not true. This is an agency that will be literally like SARS is. Money comes in, money goes out. There's a very fixed way in which it goes out. Right now, it's budgets. But in terms of what money goes out, it's based on contracting. Now, this is not individual contracts. It's not like, oh, hang on, I like Dr. Bila, let me give him something. You know, someone sitting up there can say, give a contract. It's for services. It's not for all the stuff that the provinces are currently buying. It won't happen at that level. There's no procurement. The only procurement is for services to be provided. The only people that will be contracted will, in fact, be providers themselves. So you have to ask yourself, well, if I'm getting paid by GEMS, why would there be any really different with the NHI? Of course, they have to get the competencies that GEMS has, and GEMS being able to show that they, rather than 15% in discovery, have been able to get away with admin costs at 3 to 5%. So government can do a great job. Don't underestimate that. And I think we need to just be a little more realistic. I can understand the skepticism. I'm not telling government's hunky-dory, everything's lovely, but I think that sometimes we go to the extent where we're just not common sense about things.
Yeah, and then the issue of medical aid. Will GEMS exist as it is, or discovery, or any other medical aid? You mentioned what will they cover? What illnesses will they cover, and which ones they won't cover? If just explain in clear terms the future of the medical aids.
I think that Section 33 speaks very clearly. It says that only when the NHI is fully implemented, and I'm telling you that it's a process. When it ends, I have no idea when NHI can be implemented. Yeah. So to me, that's like, when Jesus comes, what they said, Jesus is going to descend. That is just too far in the future. And I think that notion right now, to be honest, I'm not a legal person, but to me, common sense, you will have difficulty proving that when the NHI is implemented in the future, that it will be somehow compromising care. You'll have to test it. In other words, show that it doesn't do it before you can prove that, in fact, it is compromising the right of anyone. So I think that when that happens, it's going to be tested in courts by the basis of, listen, that's a GP care in the NHI, and it doesn't meet the standard that a person gets in the private sector. So I think this battle is just way into the future. Everybody said, listen, hang on to your medical aid, it's going nowhere. I think it's going to be more than government decree, and that's why I don't know why they legislated it. It's going to be the more successful they are at NHI, the less incentive to go and join a medical aid or to cover. And so people are going to come up with options that the government's going to allow it to say, listen, if you are wanting not, full half cover, you can take cover that, I have NHI and I get this additionally. So I think it's invariable. It's going to go. It's a market phenomenon. And so private sector, nothing's stopping you from being creative. I mean, the capitation system has been completely ignored by the private sector. Strategic purchasing is just non-existent, and they complain. So it's just passing the cost to the consumer, and something's going to give, and it is giving.
Yeah, sure. Well, I think if you answer the next question, because we're asking how long is it going to take, but nobody knows. And in terms of patient records, been some consideration about that, or utilizing smart cards, for instance. And this Dr. Reineck says they work in Swaziland, and they found that some patients were not pitching out for services because of they pitched without their booklets. What's the plan with the health information records?
Well, I think that there's a health standards normative framework that was set up a few years ago. It's a little bit dated, but I think it sets out saying that everything's going to work on a spine. That spine is that HPRS, that there's a single unique number, fingerprint related, for every individual. And the expectation is, yes, government is busy trying to put systems together, and they've got to get the act together. But they've got to try, and other providers have to start coming on board in all their development and start asking, you know what, how do I link up to it? Now that's more the sort of technical link, but a lot of the questions are going to be and people are doing it. You know, there are software houses already having in mind the public service, what it needs, but there isn't a crossover between them, and that's what we need to get to, is something that works for both public and private in that mix. And I think it will come along as we're going along. But I've, in work done for National Treasury a few years ago, I've said that we need to drive that process forward by setting up the performance indicators very clearly and putting them up in a schedule over the next few years, so that people understand the data requirements, and then that software houses begin to prepare themselves in terms of software to align to the needs, because information will be pretty much everywhere and anywhere based on an internet connection and a computer. So I think the need for hard copy, I think, is more the public health challenge. I think challenging private sectors don't struggle as badly, and I think they're going to find it much easier. So yes, even in Swaziland, unless there's no internet, then there's a challenge. But I mean, you know, that's pretty robust.
Yeah. Rashid Adam has an issue that you compared KK with public sector. This public sector is far much more superior than KK. Why not you compare apples with apples, so to speak? Public sector with the higher options in discovery, the more comprehensive options.
I think, Rashid, the challenge is that, you know, we must always compare apples to apples, like you say. Go to Bud Plus and go to the CHC across there. I'm sure you go to Bud Plus and go and visit that CHC, and you'll find there's not even a doctor. Asking for a glucometer is a challenge. So saying that the public service is great, yes, it's great in Liliningoy, Hillbrow, but it's not across this country. And I think what we were doing is to say, let's look at KK, and it was the only capitation scheme available. GEMS is around now, and just simply look at what does a primary care kind of ring-fenced element. So we took out dental and took out other elements that were not strictly clinic and doctor. We compared it to Johannesburg. Well, we compared it to the country's spend. So this is not like, you know, a high end. It's saying on average what was spent in the country. That's all the number I gave you. So, but please don't think that 1,200 rand in the public service gets you crazy. I mean, when I say 1,200 rand, that 1,270 rand, it's about 635 rand. Do you know what that is for? Every single visit. Do you understand what every single visit? When they come for a EPI injection, a baby, that's 635 rand a visit, not the consumable, just the service. So think about all of that. That's what it's costing us out of our tax money. So there's, in my view, a huge waste. And I'm showing you that it can be done better. I mean, yes, you might find, you know, Kike gets crap service because people see it as cheap. But I think we need to build in a culture that doesn't look at it as that, but looks at a relationship and earning well through keeping people healthy. And I think that it's a paradigm shift. But I mean, we're just trying to build up understandings.
Yeah.
And it's just a piece of information.
Coming.
Yeah.
Now, what in PLS is you say when we see 80 to 120 patients, that equates to 4 to 6 minutes per patient per interaction, and that will be minimum. You know, you will compromise quality of care, as it is the case with NHS.
I see that. I'm following the question, so I think you just tell me the question. I'll read it from there. But I think the 60 to 80, 120 patients. I mean, this is all based on scenarios. And the point in it is that it's a scenario based on data, visit rates, you know, that are public, 2 visits per person per annum, 4 visits in the private sector, like the key care has provided information, and you just compute. But at the end of the day, the way you respond, and which is what GPs responded to, is I'm not going to do this alone. I don't need to hire a doctor or 5 doctors to do this. I'll hire nurses. And we in South Africa are very well off in that we do have a good base of nurses, although it's got its challenges. We're also getting clinical associates. You have to ask yourself, do I need to see 120 also? So that's the mindset. So just simply saying, that's how do I see all this and what the minutes are, is not applying ourselves well enough to this whole scenario. I think just think back. That's why you've got to understand that if contracting comes, be more creative. And here's the opportunity to think out of the box.
Yeah. And I think one person, several people have just put these questions together, is that there seems to be no clear model. And I think you alluded to that it will take it a long time to complete this project or program. And what's going to happen to the private specialists and private medical laboratories? And also, if you can cover the allied health practitioners, will there be a role for them?
I mean, listen,
private providers,
I think that, when I explained it to somebody just in simple language, I said, listen, this is a big medical aid, but it'll feel like a medical aid, but it'll come out and it's not going to be a medical aid that offers everything at once. It's going to come out in slabs, building as we're going along. And like I said, a lot of the problem is going to be the cost, the negotiating, to say, what do you want and how much are you giving me? And that, if you're looking at how does that get informed, it's not thumb suck. There's got to be work done on it. You've got to gather data. And this is at least some data that's available. In these spaces of allied health, etc., it's going to be very challenging. And there are opportunities for them to be part of a capitation, but trying to unpack that is going to be hell of a challenging to do. I think that there might be ways in which they can be doing that, putting it out, but I think it's left to be seen how that pans out. But there's going to be a lot of arguments, I think, around that. And I think that, to me, they need to go about it slower and allow themselves time to develop models of care for all of these different disciplines, which says what kind of teamwork for a population and what is the utilization rate and the need for that team to be revised, and then the cost for that to deliver services. Of course, not just the human resource, but the other costs related to it. And that's where some price points and more rational discussion, because what people are going to say is, listen, I see 10 patients a day, as a physio. And so I'm, charge X. And so multiply that, and that's what I'm going to get. It's not going to work like that. It's going to be a very different type of approach. It's population-based. So you're going to say, well, what panel are you going to look after and how much you're going to charge? And it's not based on visits. You can manage visits, and you have to think differently about those approaches. So it's a different thought process. And I think it needs time to unfold.
Yeah. Last question.
It starts with the basic one. Yeah, thanks.
Yeah.
Go ahead. I think, the specialists.
Okay, go ahead.
Just the specialists, I mean, listen, that's, again, going to be time. And again, to me, it's going to be a function of some fees adjustments, but they're going to have to think through that a lot. But at the moment, they're talking fees. What the fees are, I'm not sure. But I think it could be much more, there are a lot more different approaches globally. In other words, there's something called, bundled packages in the US, which is about how do you get a particular condition from very low level care right through to the specialty, including hospital care. But, there are different ways to skin the cat, but you're going to have lots of sophistication for some of these things. And it's not only sophistication of the administrator, but also the providers themselves. I think it's early days, so let's see.
Yeah. Maybe last question, just looking at Professor Nibara Academic Hospital, there's Lilian Ngoyi next to it, then there's Dr. S.K. Matsiki Memorial Hospital in just one geographic region, and some GPs there. And how is that going to work, in terms of population, community, and contracting?
Well, and this is complete speculation on my part. Yeah. I can see a possibility down the line, once government figures out, and they've done it before, that they've said, listen, we want beds, and they're willing to pay you on a DRG basis, that they may say, listen, can we have you contracted to provide care to patients so that they don't go from Lily Ngoyi to Barra at the moment. They come via SK. And then you have the support of specialists in that setting of Barra that you might then refer to if there's no, if you need to have the service. But there would have to be the definition of, firstly, from Lily Ngoyi to SK, what should be referred. You refer things like if you need audiologist, there's an audiologist in the district. You don't just straight refer to SK because you think everything's there. So there's going to be very defined what is there available in SK and then what might be available in Barra. And it might be that the person says, listen, I'm not sending to SK because this person warrants an admission into Barra because of the complication level or the level of care that's available. And so they might send to Barra. And those are things that can be managed using the system which you talked about, VULA or
Thank you very much. We hear about
letters.
Yeah. It's an interesting
and last question.
Discussion,
what's stopping
of conversation that we've had.
What's stopping PHC contracting?
Oh, you want to take that one?
That one was very interesting because when I did work for National Treasury in 2018, I said to them, this can be done within 3 months, not 6 months. How long does it take any medical aid to get a scheme up? It's not years and years. It takes a few months, and they've got it on, and they constricted by their annual year. NHI can happen really quickly if it's small, well focused. And to share with you, I mean, I think there's a contract busy being developed, and it's going to come out in a few months' time, and negotiating will probably start in the next 12 months, I'm sure, engagements. But I think it's not just about the contracting, it's also about the coordination, which is what we are doing in Johannesburg, is to try and build in much more. And I think that's really important because, if a contract comes and you have no clue what you're supposed to do with this, it's useless. You need to understand what you need to go, where you need to go. So I'd strongly advise, don't wait for the contract, get involved. There's already these contracts that are available, simple ones, and in the process. I think we're there to educate you to understand what the public mandate's about.
Sure. Yeah. I don't know if... No, thank you. Yeah.
It seems I've answered most of the questions.
But bandwidth is low. Looks like it's time to...
No problem.
Pleasure. Yeah, no, you've covered quite a number
of
them, but we were unable to cover everything. Yeah.
Of course.
Yeah, thank you. But I'm going to ask, just before we close, Professor Yasmin Adam, you know very well, she works
yes.
Already with, let's say, member of the Clinical Risk Committee at the clinics to do the closing remarks.
Thanks.
So thanks very much for sharing your vast knowledge. I think you've been working in this field for such a long time. But I think one of the starting points is universal health care. And if we just say that that is what we want to get, and now there's a platform within which to go forward, I think that's excellent. I think one of the other things that just I thought about was when I was always thinking about this was that we don't have enough doctors. And now with all these medical officers that were unemployed, I think that when the time comes, they could go ahead and see whether they can contract into primary health care. And then I also just want to thank all the people that attended. It was a huge number. I think at one time there were more than 500 attendees. So a lot of interest. And I think you really explained very, very well. And then of course I must thank clinics for having this platform and allowing us to be educated, and particularly Dr. Bila for thinking about all the topics that are so relevant to us. So thank you very much, and thank you everyone. Good evening.
Bye-bye everyone. Thanks
everyone. Thanks,
thanks.
Yeah.
Bye-bye.
Yeah. Bye-bye. Have a good evening. Sure.
Bye-bye, everyone.
Bye, Zogi.
Thank you.